Every 1 meter per second your arteries stiffen, your risk of a major cardiovascular event rises by 14%. Your last physical exam did not measure this. Neither did your blood pressure reading, your cholesterol panel, or your resting heart rate. You have almost certainly never received this number. And the data shows it predicts your cardiovascular risk independently of every standard test your doctor runs. Even if your blood pressure is perfect, cholesterol is optimal, and your last physical came back clean. There is a structural aging process running in the walls of your arteries right now, and none of those tests see it. In the next 10 minutes, you will learn what it is, how to get a proxy measurement this week with equipment you already own, and which single intervention has the strongest randomized trial evidence for reversing it. Your arteries are not static pipes. Every heartbeat, your aorta, the body's primary pressure vessel, expands under force and recoils elastically. That compliance is the cardiovascular system functioning as designed. When arteries lose that compliance, the heart works harder with every beat. Pulse pressure widens. The pressure wave that should dissipate through elastic tissue instead reflects back toward the heart and brain early, arriving out of phase, adding hemodynamic load with every single beat. In a meta-analysis of 17 prospective studies and nearly 16,000 subjects, every 1 meter per second increase in aortic stiffness tracked with 14% higher cardiovascular event risk, 15% higher cardiovascular mortality, and 15% higher all-cause mortality. Linear. Dose response. Not a high-risk only signal. Here's the glaring problem. You almost certainly don't know your arterial stiffness number. Even if you've been optimizing your blood pressure, your cholesterol, your fitness, there is a meaningful subset of people who do all of that and still carry an arterial stiffness profile that standard tests don't detect. Are you in that group? This biomarker is not fixed. The structural processes that drive arterial aging are real, but aerobic exercise has RCT level evidence for moving this number, and the free protocol starts tonight. The biomarker is called pulse wave velocity, PWV. It measures the speed at which your heartbeat travels through your arterial tree. Faster means stiffer, and stiffer predicts earlier death, independent of everything else medicine currently measures. By the end of this episode, you will know 3 things. 1. The specific clinical threshold that defines elevated arterial risk, and where the research says most people unknowingly land on that scale by their 60s. 2. How to calculate a meaningful arterial stiffness proxy from the blood pressure cuff you already own. 0 additional equipment, 0 cost. And 3. This one is counterintuitive. The type of exercise with the strongest RCT evidence for reducing arterial stiffness is not the kind most people are doing. It is more specific and more accessible than you might expect. Let's understand the science first. The gold standard measurement for arterial stiffness is carotid femoral pulse wave velocity, cfPWV. It captures the transit time of the arterial pressure wave between the carotid artery at the neck and the femoral artery at the groin, covering the length of the aorta. This measurement has been validated in hundreds of thousands of subjects across multiple decades of research and is the reference standard for large artery stiffness assessment by international cardiovascular consensus. What does an elevated cfPWV actually predict? In a systematic review and meta-analysis of 17 prospective studies covering nearly 16,000 subjects followed for a mean of 7.7 years, Lakopoulos and colleagues found that every 1 meter per second increase in aortic pulse wave velocity corresponded to a 14% higher risk of major cardiovascular events, a 15% higher risk of cardiovascular mortality, and a 15% higher risk of all-cause mortality. The relationship was linear, not a threshold effect, not a signal that only emerges at extreme values. Every meter per second of additional stiffness carries additional independent risk. That meta-analysis was followed by an even more rigorous analysis. Ben Shlomo and colleagues pooled individual participant data, not just aggregate study results, but the raw data from 16 prospective studies, 17,635 subjects, and nearly 1,800 cardiovascular events. After adjustment for age, sex, blood pressure, cholesterol, smoking, and diabetes, arterial pulse wave velocity remained an independent predictor of coronary heart disease, stroke, and total cardiovascular disease. And for intermediate risk individuals, the population most likely to have unremarkable labs and a normal blood pressure, adding PWV to standard risk factor models improved patient reclassification by 13%. In the world's largest individual participant arterial stiffness analysis, 1 in 8 intermediate risk patients was correctly recategorized when PWV was measured. That is not a marginal increment. Take 2 people, same age, same blood pressure, same cholesterol, same family history. Standard medicine says their cardiovascular risk profiles are identical. Now measure their arterial stiffness. One has a cfPWV of 7 meters per second. The other has 12. Their vascular trajectories are not the same. Nothing in a standard physical exam caught that difference. This is precisely what Secelia and Chowienchik established in a systematic review of 77 studies. cfPWV captures a dimension of vascular aging that the classical risk factor panel does not predict. Total cholesterol showed no consistent independent association with cfPWV across studies. Neither did LDL, HDL, triglycerides, BMI, or smoking status. Age and blood pressure explained the majority of cfPWV variants. But cfPWV itself was not redundant with either. It is measuring something the standard panel does not see. You might be wondering whether an elevated blood pressure reading is already capturing this signal. The data says no. Willem Hansen and colleagues ran the head-to-head comparison directly. In a population representative cohort of 1,678 adults followed for a median of 9.4 years, aortic PWV maintained independent prognostic significance after full adjustment, including adjustment for 24-hour ambulatory blood pressure. Clinic pulse pressure and 24-hour ambulatory pulse pressure both lost predictive significance under the same adjustment. APWV survived. Now let's go inside the artery wall itself. What is actually happening structurally? Three converging structural processes drive arterial stiffening. The first is elastin fragmentation. The elastic fibers that allow arterial walls to expand and recoil bear an estimated 3 billion mechanical loading cycles over a lifetime. They fatigue, they fracture. This structural deterioration begins in the third and fourth decades of life and is progressive. The second mechanism is collagen cross-linking via advanced glycation end products. Elevated blood glucose accelerates the formation of chemical bridges between adjacent collagen molecules in the arterial wall, creating irreversible rigid bonds. The third process is a phenotype shift in vascular smooth muscle cells, from their contractile elastic configuration toward a synthetic proliferative form that deposits additional extracellular matrix and progressively stiffens the wall architecture. The clinical implication is important. Arterial stiffening is not a single, rapidly reversible process. Some dimensions of it respond to intervention. Others represent structural aging accumulated over decades. Managing it effectively is a long game, and the earlier the starting point, the better the return. Where does the clinical threshold sit? The 2013 ESH and ESC joint guidelines define a cfPWV above 10 meters per second as the threshold for elevated vascular organ damage. Reference values from the research literature suggest that most adults following a typical sedentary aging trajectory cross this threshold somewhere in their 60s. Without ever receiving a measurement, your standard physical exam does not include this test. It is not a required component of preventive care protocols in most countries. Now you know the track. It's time to look at the stack. Here is what to do with your number. 3 tiers and what the evidence supports. The free tier. 2 tools. 0 equipment cost beyond what most households already have. The first is a pulse pressure proxy calculation. Take your home blood pressure readings. For reliability, you need at least 3 measurements from different days averaged. Subtract diastolic from systolic. That number is your pulse pressure. Framingham cohort data following 1,924 adults across 20 years established a continuous positive relationship between pulse pressure and coronary heart disease events. At every systolic level above 120 millimeters of mercury, higher pulse pressure was associated with higher CHD risk. A persistent pulse pressure above 60 millimeters of mercury is a clinical heuristic from the broader hypertension literature that warrants clinical follow-up. This is a population-level screening signal. It is not a diagnostic equivalent to a cfPWV measurement. Do not interpret it as one. But it is the information that is sitting in your blood pressure data right now, and it costs nothing to calculate. The second free intervention has more direct RCT support for arterial stiffness reduction than most paid alternatives. Aerobic exercise. In a pre-registered systematic review and meta-analysis of 42 randomized controlled trials covering 1,627 participants, aerobic exercise training produced a statistically significant reduction in cfPWV with a weighted mean difference of minus 0.39 meters per second. In participants who entered the trials with already elevated arterial stiffness, baseline at or above 8 meters per second, the aerobic benefit was substantially larger, 1.0 meters per second. Resistance training alone showed no significant effect in the same analysis. The protocol with evidence behind it is Zone 2 aerobic exercise, 150 minutes per week at a sustainable conversational effort level, not intervals, not lifting, sustained aerobic output. The $50 tier, 2 additions on top of the aerobic base. Addition 1. Long-chain omega-3 fatty acids, EPA and DHA, show directional benefit across randomized controlled trials of arterial stiffness. A meta-analysis of 10 RCTs found statistically significant improvement in both pulse wave velocity and arterial compliance outcomes. 1 to 2 grams of EPA plus DHA daily is consistent with the dose range across included studies and with broader cardiovascular omega-3 evidence. high-quality fish oil, or an algae-based alternative for plant-based protocols, approximately $30 to $50 monthly. If you have elevated blood pressure, the second edition carries the most direct single-study PWV endpoint data in this entire episode. Dietary nitrate at 250 milliliters of concentrated beetroot juice daily, sustained for 4 weeks, reduced cfPWV by 0.59 meters per second in a double-blind, placebo-controlled BHF-funded RCT, with systolic blood pressure falling 7.7 millimeters of mercury simultaneously. That evidence applies specifically to adults with elevated blood pressure. It has not been established in normotensive populations in this literature. The $200 tier. This is the only tier where you get an actual measurement rather than a proxy. A clinical carotid femoral pulse wave velocity assessment. Available through cardiovascular specialists, preventive cardiology practices, and a growing number of longevity medicine clinics. Gives you your direct PWV number in meters per second, contextualized against the ESH/ESC reference values for your age and blood pressure strata. That number becomes the baseline against which your aerobic training and dietary protocol are evaluated at the 90-day retest. Without a baseline measurement, you are optimizing without feedback. This tier closes that gap. Episode 5. Arterial Stiffness. 4 stars out of 5, multiple meta-analyses and prospective cohorts establish the PWV to cardiovascular mortality relationship at the highest evidence tier. Pre-registered RCT meta-analysis supports the aerobic exercise protocol. Dietary intervention evidence is moderate, honest about that. Retest at 90 days. The core science here is robust. The relationship between arterial stiffness and cardiovascular events is among the most replicated findings in preventive cardiology. Some structural arterial aging is exactly that, structural. What the protocol in this episode builds is the strongest available evidence-based position against the decades of mechanical and metabolic load that drive the process. There is one consequence of arterial stiffness we have not discussed yet. Stiff arteries reduce cerebrovascular perfusion. Blood delivery to the brain becomes less stable, less responsive, less adequate under demand. The brain has a defense mechanism against this, a nightly waste removal system that clears the toxic byproducts of vascular stress. But it only runs under very specific sleep conditions, and the condition most people think they've already satisfied, 7 or 8 hours, is not sufficient on its own. What matters is the architecture of that sleep, the specific proportions of deep sleep and REM. That's exactly what episode 6 covers. Subscribe so you don't miss it.